time for introduction. There's not too many of us, so we will definitely have a round of introductions, which I'm sure the chair will take care of. But because of the time constraints, we will just jump straight into the program for now. If you look on the program, there's supposed to be can I kindly have the projection there? We're supposed to have the welcome and purpose of the gathering. Now, I've often wondered about this tradition of the purpose of the gathering, because once people gather, the presumption is that they know why they have gathered. But nonetheless, it is always good to spell out so that if anyone is in the wrong place, they have the opportunity to excuse themselves. So we are here this morning, and let me just point out that the channel 2 is for the French translation. So for those of you who would prefer to follow in French, please use channel 2 on your device. You must be familiar with this. So you turn it on here, and then you change the channel on my left-hand side. You can change that to the French channel if you need it. So this is the first in the hopefully a series of policy dialogues, and is the first biennial West African policy dialogue on pandemic preparedness. And we have themed this capabilities for better data, better analytics, and better decisions. Our chairpersons and others would get into the details of this. And we have many of you who have come from Europe and also from West Africa to join us, and we are really elated to have you. I know that a number are also on their way. His Excellency, the Commissioner of Health for Lagos State, I know is on his way, and a few others too are on their way. I'd like to right away request Dr. Linda Deborah to come and introduce the chairperson, and then we will go from there. So Linda.
Thank you very much, Dr. Amoisi. This morning, we are happy to be gathered here, and as a gathering, we will need somebody to steer the affairs. We are very proud and we are happy that the person who will take the seat is a proud son of the Kwame Nkrumah University of Science and Technology. He is a researcher. He has been researching in global health for so many years. He has worked with the Kintampo Health Research, even for about 17 years now. He's currently with KNUST as a professor and as the Dean of School of Public Health. He is a professor in global health. Ladies and gentlemen, I'm very happy that even our chair is also a member of the G-WAC committee. Please, let's welcome Professor Samuel Newton. Take up the chair. Thank you very much. I'll then hand over the mic to him so he continues chairing the affairs.
Hello. Thank you, Linda, for the introductions. My work has been made very easy because of the part John played in introducing the reason why we are here. So first of all, we want to welcome you all to this meeting. As he said, capability for better data, better analytics, and better decisions. And we hope that from the lectures which we'll be hearing, we'll be able to learn something which would improve the work which we are doing. We from KNUST are delighted by G-WAC. Already G-WAC is a household name on KNUST campus because of the good work which is happening. And really appreciate and welcome you all from the West African states and also from Europe who have come here to join us, and more especially our guests who we invited who have also come here to be with us. So thank you very much, and we'll go straight to the program and take a message from the German ambassador, His Excellency Daniel Krul.
All right. Good morning, Chairperson, Deputy Minister of Health, Deans of Colleges of Public Health, and Acting Directors of G-WAC, distinguished dignitaries at the high table, distinguished participants from Ghana and beyond. Bienvenue, welcome à tous les participants du monde africain de l'Ouest. Today is a very exciting day, not because of your seminar, but because Germany might be kicked out of the World Cup today. So we are all very excited. I understand you all know why you are here. I would be surprised if not. Just maybe let me then focus more on why Germany and why the German government is supporting G-WAC and why we are so happy that we have today the first dialogue on pandemic preparedness. Our support for G-WAC is part of a pattern we follow in the support of building networks in West Africa. Germany, since more than 25 years now, is supporting the KCCR in Kumasi. We are supporting in social science the MIASA project and University of Ghana, and we support the Pascal Institute, which is a gathering of 11 countries working on livelihoods in times of climate change. So as you can see, all these institutions have one focus, and the focus is on building regional networks. And this is my understanding of G-WAC as well. In the field of pandemic, it's our main interest is supporting you in your aim for capacity building in your respective countries. And we hope to strengthen the networks with you, because we all know that the pandemics are not over. They will come back, that's for sure. We don't know how and when and where, but we need to be prepared so that once they pop up again, that we all together jointly find responses to the challenges in a very timely manner. So with this, I would like to wish you a very fruitful seminar and looking forward to hearing from you about your results. Thank you very much.
Thank you, Ambassador Crew. Thank you. So we are now going to have a message from the provost, and to deliver the message is Professor Daniel Anson, the Dean of the School of Medicine and Dentistry, KNUST.
Thank you, Sam. Right, so I bring you warm greetings from Kwame Nkrumah University of Science and Technology on behalf of the Vice Chancellor, the Pro-Vice Chancellor, the Provost, and the entire faculty of the College of Health Sciences, which is the host of the G-WAC program. It is a privilege to have this opportunity to lead this very important agenda. And the message from the entire university to this gathering is to support the initiative that the directors have taken on, and believe that with the appropriate collaboration, networking, and partnership, as well as good stakeholders engagement, we should be able to address challenges that are posed by emerging diseases on our continent. That note, I would thank you all for coming, those who are traveling within West Africa and from Europe, to this very important meeting. Thank you very much.
Thank you, Prof. Anson. We want to invite Professor Wilm Quentin, the director of G-WAC, part of the G-WAC process, to give the opening comments, after which we would have the Deputy Minister of Health to give her speech. Thank you. Wilm.
Yes, thank you very much. As the director of G-WAC, you may know that I'm from the Berlin University of Technology, but what you maybe don't know is that I have also worked for a long time for the European Observatory on Health Systems and Policies, because at the Berlin University of Technology, we are one of the hubs of the European Observatory. And the idea for this policy dialogue really goes back to this European Observatory on Health Systems and Policies, which aims to bridge the gap between policy making and research, or between research and policy making. It's a bi-directional gap, I would say, and the purpose is to support evidence-informed policy making. And the policy dialogues are one of the approaches of the European Observatory to bridge this gap between research and policy making. And I would like to highlight a few characteristics of these policy dialogues, which I think are important and which we should bear in mind now for the next 1.5 days, as we are here together to discuss the capabilities for better data, better analytics, and better decisions. And this is that first, policy dialogues should ideally be demand-driven. So when the European Observatory is doing a policy dialogue, usually there's a request that comes from a national government or from a group of national governments to support them in making a new policy or preparing a reform. And in this case, because this is a new initiative to establish the West African Policy Dialogue, we didn't yet have a request from a government to do this, but we believe that with starting this initiative, we can generate the momentum to get this institutionalized, hopefully within the next 2, 4, 6 years, and that in the future there will be really requests from national governments in West African countries to receive evidence from researchers who are part of G-WAC, but also from other researchers in the region to support them with providing evidence for new policies. And another point is that these policy dialogues should be neutral, and that's always when evidence is presented and we are presenting evidence, we do this in a non-prescriptive way. So because usually there are many different options to address certain problems. And so these different options should be put on the table by the researchers and explained what are the benefits and disadvantages of these different options. The policy dialogue, I hope, will be informal and neutral, and nothing should leave the room. Usually we say that they are following Chatham House rules, so that means everything that is said will stay here in the room and shouldn't go out. You may see the media right now, but they will leave after the opening ceremony to make sure that everything can be put on the table, openly discussed, that we can address differences between research and policymaking, that data problems in different countries can openly be discussed and shared amongst each other, because it is important to put these things on the table in order to be able to address and discuss how they can be solved. And policy dialogues are usually focused, tailored, targeted, so they really, once there's a question that should be addressed by the policy dialogue, there are several iterations where we usually go back to policymakers to ask what is really the problem that needs to be addressed and what are the topics that we should discuss within the policy dialogue in order to be able to address this policy problem. And the idea is often also that by bringing policymakers and researchers to the table, that the researchers provide the evidence, but the policymakers then provide the context, and the context they know really how this evidence can be implemented, and how this evidence can inform the policies, what the researchers often are not aware of. And this means that in the long term, there should be ideally shared ownership between researchers, and we are only starting this initiative, but in order to be successful in the long term, there has to be also a buy-in by either regional international organizations or national governments in the West African region. And the reason why we thought this initiative was useful and it would be possible to introduce this is because 5 years ago, we started a Ghana health policy dialogue as part of another project. And we have just come back from a 2 days Ghana health policy dialogue in Ho here in Ghana, where we discussed with several people of the Ministry of Health and of the Ghana Health Service, the National Health Insurance Authority, possibilities to assess the performance of the Ghana health system. And it was a very active, very open meeting, and the problems were really put on the table. and like we learned what the problems are in between for researchers to get access to data because they don't show sufficient respect for the policymakers who have the data. And there were really open, very live discussions about this. And the policy dialogue, although we started it more or less, the idea 5 years ago, it's now really owned by the ministry, and they define the topics for the policy dialogue that usually come up out of the health summit, and then we gather together and provide evidence that can inform the policies. And I hope that once the media has left the room, we will have as open and vivid discussions here over the next few days, because the topic is so important that nobody should be afraid to really put the things on the table and spell out the problems clearly that they have with data analytics and decision making. And with that, I would really like to give back to the chair.
Thank you, Professor Phil Quentin. Next, we're going to have Honorable Tina Mensah, the Deputy Minister of Health, who is representing the Ministry of Health, to give her opening remarks. Thank you.
Thank you, Prof. Prof. Chair, Your Excellency, the German Ambassador to Ghana, Provost KNUST, Director G-WAC, WHO Directors and Heads, distinguished participants, ladies and gentlemen. I am honored to join you in the first biennial West African Policy Dialogue on pandemic preparedness with the theme, Capabilities for Better Data, Better Analytics, Better Decisions. I am informed that this biennial West African Policy Dialogue on pandemic preparedness is part of the novel initiative of the newly established German West African Center for Global Health and Pandemic Prevention, based at the Kwame Nkrumah University of Science and Technology, KNUST in Kumasi, and is designed to support the global health agenda to build capabilities for better data, better analytics, and better decisions for emergency preparedness and response. This forum is very timely, especially in the aftermath of the recent global COVID-19 pandemic, Melbourne virus disease, and monkeypox outbreak, among many. For us in Ghana, we have adopted a multi-sectorial, multi-pronged approach in response to these outbreaks, and the level of commitment remains high. However, the importance of timely, reliable, and relevant information for timely decision-making before, during, and after this event is highly crucial in any country's response and in the sub-region. The ministry has put in place surveillance and data systems to ensure the timely availability of data to inform the various stages of public health events through prevention to detection to the response. These systems have provided the bedrock for launching and tracking of our response systems and provide the relevant information to inform governance, coordination, and accountability decisions, and also to ensure that the impact of events are minimized. It is, however, important to note that just having the data available does not translate into the necessary response until the data is analyzed and utilized to inform strategic decisions related to response to pandemic and epidemics. Additionally, the role of the health research in producing some of the data cannot be overlooked. Instituting such a program within the West African sub-region also empowers us to make timely response decisions, contain events, and address cross-border transmission. Such a program will provide the impetus and information for a strengthened cross-border collaboration in response to events. I must emphasize that we live in a global village, and whatever happens across our borders should be of concern to us and should impact on our individual and joint response decisions. We are grateful to be the partner KNUST College of Health Sciences in Ghana, the Berlin School of Public Health, including Technische Universität, yeah, I'm speaking Germany, Universität Universitat, yeah, Universitat Berlin, and Chaite Universitat Medizin, Berlin, and Medical Faculty and University Hospital Bonn in Germany, and the Robert Koch Institution for instituting such a project. I believe this project will go a long way towards contributing to building the relevant capacities for evidence-based decision-making for effective response. I will urge all the collaborating partners to continue to work closely to ensure that objectives outlined for the project are met. Thank you, and I wish you a successful meeting. And may I add to it, I wish I could stay with you throughout the program, but I have another call to be in Parliament within the next few minutes. So I'll take my leave after this. Thank you very much, and God bless us all.
Thank you, Honorable Tina Mensah, for coming and attempting to speak German. We really appreciate your efforts. So thank you very much.
You're welcome.
So you may leave. Okay, I think it's appropriate that we introduce ourselves so that we know who is here and who we are. So we would start, I think I would start off and we would go clockwise. So I'm Sam Newton, already introduced, the Dean of the School of Public Health, KNUST. So I think we would go this way. So just introduce yourself so that we know who you are. Just a round of introductions. Thank you, Tina.
Okay. Hello, so my name is Anna Meyerkort. I'm a medical doctor by training, and I am part of the Robert Koch Institute. I'm a researcher there, based in the Center for International Health Protection. And I am basically part of the project that we conducted to help with the strategic rollout of the WHO Hub for Pandemic and Epidemic Intelligence.
Thank you.
Thank you. My name is Joanna Hannefeld. I'm the director of the Center for International Health Protection at the Robert Koch Institute in Berlin, Germany's National Public Health Institute. And I'm also a professor of global health policy at the London School of Hygiene and Tropical Medicine, and in that role, part of the G-WAC consortium.
Thank you.
My name is Achim. I'm Director Chair of the Institute of Medical Microbiology at Bonn University Hospital Center. So we, as you might have known, there is Berlin and Bonn and KNUST. So in a tripartite consortium that we are leading the G-WAC, and I'm one of the coordinators from the Bonn side. My research is mainly focused on NTDs, and we bring in here NTDs sort of as a litmus and basis for capacity building and also lab knowledge in order to be better prepared for the future.
Yeah, I'm Walter Bruchhausen from also the University of Bonn, where I'm the professor for global health. I'm the co-director of G-WAC for the Bonn side, and in my own research and teaching, I mainly focus governance issues, which are, as we all know, extremely important in issues of pandemics. So the trust of the populations, the influence, possible influence on human behavior is central in overcoming the threats and the challenges of pandemics.
My name is Christine Müller. I'm from the International Office of the University of Bonn, and I'm here at our Erasmus program. So this is an Erasmus staff week for the two of us, and we try to support research and scientists best from administrative side. And so I'm happy to learn what might be needed. Thank you.
So I'm Hannah Weisheit. I'm currently doing my year of voluntary service in the International Office of the University of Bonn in the department of Christine Müller. So I'm here for the same reasons as her.
Hi, my name is Philippe Peldieu. I am a research scientist with the Institute of Virology Charité, conducting collaborative research projects in virology in Ghana and other African countries, and I'm a scientific coordinator on G-WAC.
Hello, my name is Linda Deborah, and I'm with the Kwame Nkrumah University of Science and Technology as a medical parasitologist working on NTDs with filariasis as the main focus. I'm a member of the G-WAC management team.
My name is Gordon Awandare. I'm a professor of biochemistry, soil and molecular biology at the University of Ghana. I'm also the founding director of the West Africa Center for Cell Biology of Infectious Pathogens. Our center is involved in genomic surveillance and as well as seroprevalence studies for the current pandemic response. Thank you.
My name is Daniel Opoku. I am a lecturer at the KNUST School of Public Health and also a research scientist at the Department of Healthcare Management and Berlin University of Technology under Professor Reinhard Busse. And I also lead the eHealth Research Partner Group at the KNUST. Thank you.
I'm Alexander Adebra from KNUST. I'm a former Dean of Faculty of Allied Health Sciences, and I'm a professor of NTD and Global Health. I'm part of G-WAC management team at KNUST. Thank you.
Yeah, I'm Benjamin Emife. I'm the Dean of the School of Veterinary Medicine, KNUST, the lead for Ghana in the area of zoonosis in G-WAC. I'm a professor of diagnostic pathology. Thank you.
Hello, I am Rodion Konu from, I'm medical epidemiologist at the University of Lomé and University of Bordeaux, Global Health and Global South team. So I think that's all.
Hello, my name is Romain Glele Kakai. I'm professor of biostatistics at the University of Abomey Calavi in Benin. I'm alumni of the Alexander von Humboldt Foundation, and currently I'm coordinating a Humboldt research hub on socioecological and spatial-temporal modeling of COVID-19 in Africa. Thank you.
My name is Ali Sie. I'm a medical doctor and technical director of Nuna Health Research Center in Burkina Faso. That is part of National Institute of Public Health at the Ministry of Health in Burkina Faso. I'm working in global health, mostly health system management and performance. And I'm also responsible of the Health Information System program at the National Institute of Public Health. I did some work on evaluation of health information system in West Africa countries, including Burkina Faso, Togo, Guinea, and Sierra Leone. And thank you.
Merci. Je vais m'exprimer en français. Je me nomme Sano Théophile. Je suis médecin de santé publique. Je viens du Burkina Faso. Je suis du ministère de la Santé et je coordonne une unité qui a été mise en place pour gérer les transferts de connaissances et également tout ce qui est performance et résultologie au niveau du ministère de la Santé. Donc, cette collaboration avec les chercheurs pour influencer les différentes décisions au niveau des autorités. Merci.
Hello, I'm Kwasi Damus Paquin. I'm from Côte d'Ivoire. I'm professor of public health at the University of Alassane Ouattara, and I'm also head of the epidemiological surveillance in Bouaké at the National Institute of Public Hygiene. Thank you.
Morning, everyone. I'm Abdul Salam Wedraogo. Oh, sorry. Oh. Okay. So I was talking alone. I'm Abdul Salam Wedraogo from Burkina Faso. I'm professor of clinical microbiology, and I'm right now the director of Centre Muraz, that is part of National Institute of Public Health. Our center is an historical center of Burkina Faso, even in West Africa, focused on pandemic fighting. And we are hosting right now 2 reference labs, National Reference Lab on antimicrobial resistance and National Reference Lab for hemorrhagic fevers. But at individual site, I'm coordinating right now a technical working group in West African WAO, West African Health Organization, to build regional surveillance for antimicrobial resistance. Thank you.
Hello, everyone. My name is Julius Gedeinen. I'm from Liberia. I work at the National Public Health Institute and serve as the Deputy Director General for Technical Services at the Public Health Institute of Liberia. At NPhil, we primarily responsible for detecting and responding to public health threats and for research activities within Liberia. So in my capacity at the Public Health Institute, I provide supervision for public health and biomedical research activities in the country, as well as emergency response, disease surveillance, training, capacity building, etc. Thank you.
Okay, good morning to all. My name is Stephen B. Kennedy. I'm from Liberia. I'm the thematic lead for infectious diseases at the ULPI Africa Center. It is an infectious disease research center based at the University of Liberia. Over the past multiple years, I've been actively involved in research on clinical trials, community-based, and also policy-related research in regards to outbreak response, especially regarding the Ebola virus disease, COVID, as well as loss of fever in Liberia. It's good to be here. I look forward to learning from experiences that will be shared at this forum. Thank you very much.
Hello. Yeah, my name is Ernest Kunedu Esedu. I am also a medical epidemiologist by training, and currently working with the National Center for Coordination of Early Warning and Response Mechanism. Our focus basically is on anything that threatens human security. And by my role, I'm representing the Ministry of Health in that center, but the focus ultimately looks at terrorism, extremism, violent extremism. We are looking at crime and criminality. We are looking at health, pandemic-related issues. We are looking at environment, social and economic challenges. We're looking at governance, leadership, and then gender as a cross-cutting issue. Our function is basically as in Ghana. Yes, so Our function is basically to coordinate human security challenges in the country. It's an ECOWAS and a country creation. So we have similar institutions in other ECOWAS countries. Currently, 12 of them are established, except for Togo, Senegal, and Cape Verde that are yet to establish their own. But we work across the borders and we share knowledge and then also pick other information from other countries so that we can manage anything that threatens human life. Thank you.
Reinhard Busse. I'm the head of department of healthcare management at the Berlin University of Technology, one of the co-directors of the European Observatory on Health Systems and Policies, and director of the Berlin School of Public Health, which is an inter-university school. And as such, in my department and in these other institutions, we look at the role of health systems. We first did that, and we're still doing this, as Wilm, who's with me in my department, has already said. We first looked at European countries. We have the WHO Regional Office for Europe as a member in the observatory. We have the European Commission. We have many country governments, and we are set out to bridge the gap between what we know about health system functions, how they are financed, which results are achieved in terms of health, equity, cost effectiveness, responsiveness. And we have expanded that some time back also to African countries, not only first to Ghana under a previous project which led to the policy dialogues in Ghana, but now more recently, and together with our colleagues from the Charité and the University of Bonn in this G-WAC exercise. And I'm happy to be here and that we can share our knowledge about health systems in general with a more specific aspect of the pandemic preparedness. Thank you.
Good morning. I'm James Deere. I work with G-WAC as the Deputy Executive Director. I'm a public health physician. G-WAC, we are the second largest provider of health services in this country. We have presence in all the 16 regions and specifically in about 200 districts. Our institutions collaborate with many of you who are doing research. We've played quite a key role in the COVID-19 pandemic response, especially in districts where the government doesn't have facilities. I think at the moment we are collaborating with WACBIP, and some of our staff provide data for the genomic sequencing. We also work with KCCR, some of our institutions, Agogo, Asimfosu, and the rest. We actually are the receiving end of the research that you do, and which is why I'm happy to be here. That all the research and policies should translate into good service delivery. So I'm very happy to be here. Thank you very much.
Thank you for the introductions. We have already been introduced, so we'll go straight. We are going to have a keynote address by an online presentation by Dr. Chikwe Ihekweazu, the Director of WHO Epidemics and Pandemic. We're going to have some concluding remarks in this order. Dr. John Amoesi will be the first to speak, then Dr. Wilm Quentin, then also Johanna Hannefeld will also be speaking, then Professor Arindara, and to be ended by Prof. Akim Horof, in that order. But because they didn't give us a screen, we have to move here so that at least we can see what's happening here. So we can go down now. Thank you.
So good morning, colleagues. Thank you very much for the kind invitation. It's I would have loved to be back in West Africa to do this physically, but unfortunately it was just too difficult to arrange travel. So I'm really glad, and it's a personal honor to me to have the opportunity of sharing a few thoughts with you. And thank you, John, and all the colleagues for the invitation. I can see you have a full room of colleagues from around the world, especially colleagues that have traveled from Germany. So welcome to West Africa as well, to all of you. So sadly, I'm a little bit pressed for time, but I will try and share a few thoughts with you. This topic is very important for us. My name is Chikwe Ihekwazu. I am an Assistant Director General at the World Health Organization, responsible for health emergency intelligence systems and surveillance systems. It's a new division in the emergencies program and also incorporates the Hub for Pandemic and Epidemic Intelligence in Berlin. So I'll share a few slides to help me navigate this presentation. So I hope it's showing. I can't hear you, so let me hope that you can hear me and see the slides. I think I can see it on the screen. So, firstly, like I said, I lead this new WHO Hub for Pandemic and Epidemic Intelligence in Berlin. A few words on why a hub, why have we set up this new hub in the organization? As we went through the pandemic together, and I was in Nigeria at the time, leading the Nigeria Center for Disease Control, there was a shared experience that we had with almost every other country in the world, that our ability to collect, analyze, use data for decision-making and have the agility and the flexibility to do it in real time in order to inform our political leadership on what is going on and the action they need to be taken on a day-to-day basis was stretched to its very limits. So every one of us struggled. Whether you were leading the response in Ghana or in Egypt or in Germany or in the US or in Russia, everyone was struggling with the same challenges. How do we understand what is, not only what is going on in my country, but what is going on around the world? And how do I use that information to make decisions, the best decisions for my people in the short and long term? And we will all agree that in many cases, we got it wrong. And even when we tried our very best to make those decisions, we really did not have the framework to consider everything that we needed to. And countries that were very proactive in sharing information sometimes were punished significantly politically for it. There were other consequences of sharing, other consequences of not sharing. And basically the landscape for how to use data to make decisions, which is the theme of this gathering, has never been more important. And really that's the thinking that led to the establishment of the WHO Hub for Pandemic and Epidemic Intelligence in Berlin, which I've now led for right about a year. So I thought by taking us through a few thought models on why surveillance and intelligence matters, so we can reach some consensus around this, share with you some of the initiatives going on at the moment, and end with a little bit about the hub itself. So firstly, on why surveillance and intelligence matters. You know, this is a really challenging space because success in the work that we do does not lead to any headlines. So when you do surveillance successfully at the local level, you identify threats and you respond to those threats effectively, no one ever hears about your work. This is just on the picture, a few examples analyzed by a group of colleagues on incidents that could have had all the characteristics to become significant outbreaks with significant costs in morbidity, mortality, and economic implications that no one heard about because the response was good, surveillance worked, the event was detected and responded to, and it became more or less a non-event. And for well-functioning systems, there will be several of this happening every single day. At the global level, we hear of many plans around pandemic prevention that seem to assume that it's self-evident that a new incident will become a pandemic. There are many discussions about a 100-day plan, 100 days to that, assuming that when a new pandemic emerges, we will all understand that this incident will become a pandemic. But I put it to many of these colleagues that there are many incidents that happen every single day that colleagues like yourself detect and respond to that could become one, that never become one, either because the local circumstances don't allow that to happen, or our surveillance and response architecture and infrastructure has worked. And this is important for us to remember, because it's only in considering this threat as a continuous global threat that we can frame the response to it. If we think about it as a single Big Bang effect that will happen in obvious circumstances, then we will lose really the real incentives to do the work that we need to do. And the other thing to emphasize here is what we understand as the value of surveillance is also variably defined and by different people, and also by different perspectives, all of which are correct, but none of which are sufficient to give you the full spectrum of what surveillance should be doing. And very often, depending on your perspective, if you're responsible for epidemic and pandemic response, then you're very interested in detecting new and re-emerging infectious diseases. And many of us in West Africa have had our fair share of those and continue to have them and have to deal with that almost on a daily basis. But there are many other colleagues that are more interested in measuring the success of their disease control programs. If we think about a disease like measles, we've had an effective vaccine for 60 years, one of the most effective vaccines in the world, a vaccine that costs very little, yet we still have significant outbreaks of measles. So it's not just a question of new detection of new diseases in order to develop a vaccine rapidly. It's also the challenge of how do you monitor our performance as public health managers in the control of significant diseases that are still in circulation. And obviously, a new area of focus is on the elimination of disease as well. Not new, because we've been working on polio for many, many years. And for a while, you know, there's a lot of fatigue in the response, global architecture of response to polio. And the development of new tools using wastewater surveillance, for instance, which has detected the virus in the sewage systems in London and New York this year, has really emphasized the global threats that we continue to face and how we have to continue to respond to this, and our responsibility in developing new tools to this continuously. And also, when we think about infectious diseases, you know, we also have to remember that the risk is not constant, and the risk will change depending on several factors, some of them man-made, some of them natural, but all of them lead to an impact an effect on our risks and vulnerability. So whether these are wars in parts of the world that haven't had this for a long time, or in areas of conflict that are ongoing, whether this is hurricanes or floods. We've seen an incredible amount of floods in West Africa this year, especially in Nigeria, as well as in Pakistan. All of these increase the complexity and severity of our challenges. And if our data systems are not inclusive in understanding these risk areas, then the monitoring of just the incidence of infections is not enough to understand where we are. But there's also some good news. Yes, areas of risk are increasing globally, and all of these are kind of global estimates. But there are many other factors that are also leading to that increase. But in a way, these can't really be seen as risk areas, even though they lead to a variation in risk. We can see an increase globally, incredible increase in the number of air travelers, in the exports of goods and services, in the growth of urban populations. And if we're not measuring and monitoring and understanding the interplay between these, and these are just a selection of three, there are many others I could have put on this slide, then we are not in a really good position to understand how to respond. So the functions of data, better analysis and better decisions is not only in the simplistic understanding of surveillance as it has been defined by many national public health agencies and ministries of health, but it's really in understanding all the other factors that lead to a variation of risk and vulnerability to infectious diseases. And if we don't include these in the thinking towards our decision making, it is not likely that we will make the right decisions for our people. So we have to really understand the full spectrum of what leads to the risk. And if we are not prepared to do so, either by how we have organized our institutions, the systems that we use, the collaborative environments that we create, then we are not in a position to really be confident in our ability to make these decisions. So a few points on the overview of our current landscape and what we're doing about it. And this is very important for you to know, even if you're not involved in the day-to-day transactions of it. But there is a significant focus on this now post, I wouldn't say post-pandemic, but at this stage of the pandemic, that we are all thinking collectively on how to respond to the realities of what we have just gone through. We can't come out of this pandemic and pretend to continue with business as usual. So at the global level, there are fascinating conversations going on at the moment around three spaces. And if you look at the bottom, I don't expect you to read any of the documents up there, but if you read anything, read the three words at the bottom of the four documents. Two of them relate to governance. So significant discussions going on right now between member states. So Ghana is very much involved with this. Germany is very much involved on a new pandemic accord. So really redefining the governance. How do we hold each other accountable for a certain minimum of activities when we detect a risk? And what do we ensure that within our global community, we hold each other accountable to do? WHO is only the secretariat for these discussions. The discussions and the decisions will be among countries, so member states of the organization. And you will, or our countries will decide for each other what they are obliged to do as a responsible member of a global community. And really that's what the new pandemic treaty or accord, whatever term member states ultimately decide to call it, will use. There are also interesting reforms in the international health regulations being discussed at the moment, recognizing that international health regulations, as they are currently prescribed did not really optimally serve our purposes during the pandemic. So that's in the governance space, very important. The other space is in financing. Now, there's a new pandemic fund that has just been agreed. The name has just been agreed, to which many countries and philanthropic organizations are now committing funds. So there will be actually a fair amount of money available globally for pandemic preparation activities. The challenge, however, is unlike the funds available historically for the big global health initiatives like HIV, TB, malaria, Gavi for immunization. The areas in which to invest in for pandemic preparedness are not as clear as it was for Gavi, for instance, which was largely around the procurement and delivery of vaccines. For HIV, it was largely about the procurement, delivery mechanisms for diagnostics and antiretrovirals for HIV. For pandemic preparedness, the what to invest in is not clear. What exactly do we invest in to make us safer from the threats of infectious disease outbreaks? And that are the things contained in the last document, 10 proposals to build a safer world, where we're currently going through a lot of thinking in how do we redesign the health emergency preparedness and response architecture globally to make the world a safer place. And it is a very complex conversation going on to define exactly the what. This what, as it is being designed at the moment, we have put together a proposal by the DG of the World Health Organization in this document that contains 5 what we call interconnected health emergency preparedness and response subsystems. And of these subsystems, one of the most important ones is a term called collaborative surveillance. And that's a term that we are working within the hub in Berlin and our surveillance department in Geneva to define. The other subsystems are around community protection. So how do we learn from all the public health and social measures that we delivered during the pandemic? The second is on clinical care. Very often, these have been separated. So the responsibilities for delivering clinical care have never really been considerably part of a public health response. But during the pandemic, we have seen how interconnected these are. And in order to make this work, we have to have a public health perspective to the delivery of clinical care globally. We have to think about scalability, provision of countermeasures such as PPEs, oxygen, as part of a public health response, not only as a provision of clinical care. How do we define countermeasures themselves, whether they're PPEs, vaccines, therapeutics, and all of that? And in the middle, we have coordination. But I'll focus my last few minutes on the concept of collaborative surveillance. Now, when we speak about collaborative surveillance, and colleagues, you will increasingly see this term in the global landscape in the next few months. So we're in a very privileged position here in Ghana today to be able to discuss this in detail, because this is a theme that will define our conversations in the next few months. What is collaborative surveillance, and how are we beginning to define this? So this is being defined around 4 dimensions. The first is across disease areas. So this is really taking the concept of integrated disease surveillance a step further, but as only one of the 4 dimensions of collaboration. So firstly is collaboration across disease areas. Secondly is collaboration across sectors. So really operationalizing the One Health concept and making sure the data flows find an intersection between each other. Collaboration across the event lifecycle. So the detection, we very often focus on the ability of surveillance systems to detect new trends or incidences, but it's not only the detection of new threats, but it's how resilient is the system to monitor the disease and the impact of the disease throughout the event. And at certain points, the incidence is not as important as mobility data. Are systems well structured to get capacity data out of our hospital systems and things like that in order to understand the impact on the health system altogether? And thirdly is collaboration across geographies. And when we think about this, all of this needs to ultimately lead to better decisions. If our efforts are not leading to better decisions, which is the goal, then we are missing the point. So if we integrate around these three subsystems across those four dimensions, and the imagery of a rope here is not coincidental, because it is our goal is for the rope symbolizes the strength of a collaborative effort, and that each of this is stronger than each of them individually when they work together. And ultimately, that we are in a better position that our leaders and our leadership and our ministers and whoever is making those decisions are in a better position to use our input to make those decisions. So that's a new concept that we're offering the world to move forward on, and really focusing that it is not enough to develop capacity. We also have to develop our collaboration. So it is not enough for any country in West Africa, for instance, Ghana, Sierra Leone, Nigeria, to develop its own capabilities. The strength that we have is how much we collaborate across. And not only collaborate across countries, collaborate across sectors. How much is the human and agricultural sectors collaborating operationally in defining risks? And if we don't achieve this, then we don't get to the optimal position that we want to. I will start concluding with a few thoughts on the hub itself and on the work that we're beginning to do here in Berlin. This is the response cycle that everyone working in outbreak response is aware of, from prevention to preparedness, response, and recovery. Every country has an institution with which to do this. In some countries, they are delegated to a national public health agency. In others, they are within a department in the Ministry of Health. Now, what we're doing is, in addition to this, really develop an infrastructure to do something, and you will recognize this theme because it sounds very similar to the theme of your dialogue session today, and really to develop the systems to use better data for better analytics in order to make better decisions. But basing all of this on the surveillance infrastructure that a country has set up already. And this in itself is what defines the hub that we're setting up in Berlin. Our objectives are not to collect data from around the world, but in a way to connect data in order to keep the world safe. So a good analogy is air traffic control. So if you think about the skies and our airlines, there's no one agency that collects all air traffic control data in order to manage our skies. Yet we have very few accidents. This happens because each country's air traffic control authority has developed a framework in of itself to communicate with each other. And so with that framework, the entire web across the skies is kept safe. So we have to think about our infectious disease space at the same time. It is possible to share information while still keeping a lot of the sovereignty that we tend to hold dear. We will innovate around new systems, new technologies, new ways of working to support the work we're doing. And of course, none of this is possible if we don't strengthen the existing human resources, staff, and systems that we already have in each of our countries. So this is just a high-level image of our new work. The light blue defines the new division. So the emergencies program in WHO was previously comprised of a preparedness and response division. And now we have intelligence and surveillance systems division as part of it to create this new architecture to support the preparedness and response work. And of this shaded part is the part that is defined as the hub that is based in Berlin, while the rest are based in Geneva. I won't go into all of these. These are all the projects within our division. Some of them are aimed at norms and standards. Some of them are capacity strengthening. Some of them are delivering services directly. And some of them are around the strategy and policy space. Just to recognize that there are many colleagues from the Robert Koch Institute in the room, and we are working very closely with them around specific projects around public health intelligence, genomics, and the fellowship that will enable colleagues from around the world come to Berlin and work with us on specific topics, especially fellows from national public health agencies in countries. And I hope that this will be a mechanism for many people in the room ultimately to access the opportunities of collaboration with the hub into the future. Our work has involved also a lot of thought leadership. One of it is with Charité. Charité is the biggest hospital group in Berlin, academic hospital in Berlin. And together with them, we've set up a speaker series and many other projects in different stages of development as we try to define this space for the world. I'll skip this slide for interest of time, but you'll have access to it. One of the most important areas is a new space on genomics. And one important project for us is a new international pathogen surveillance network that we're setting up out of the hub. And through the last year, we've worked very hard in catalyzing not only our work, but in all our partners. And that's the reason I am attending this session today, to really pull in. We are creating a collaborative space, both physically and in terms of our breadth of collaboration, and really invite all of your ideas and yourselves to join us as we think about the future that we are trying to create together. So thank you very much for the opportunity, John, colleagues. It's been a real pleasure. I honestly wished I was able to come to Ghana today, but at least I've shared a few thoughts with you. I look forward to your feedback. Unfortunately, I can't stay for too long, but I wish you a successful meeting, and I hope that these few words inspire some of the conversations that will happen for the rest of the day. So thank you very much for the opportunity.
Thank you very much. For this, I'm sure there will be a question or two, maybe a burning question or two, and we'll be happy to take them. Okay, John.
Thank you very much, G-WAC, for joining us. Apart from the depth that you provided and the content, just you taking the time to prepare this and spend with us is something that we appreciate very much here in Ghana, and also from G-WAC in general, given that this is really the WHO area where G-WAC really would be interfacing the most with. You touched on a couple of things, and I liked in particular what you spoke to regarding being able to appreciate the risk, and you made mention of what I would maybe summarize as complex socio-ecological systems. And given that these are so complex and require multidisciplinary approaches to them, I'm just interested in how the hub plans to make use of networks like ours, G-WAC, to feed the hub with the required information. What's the mechanism for receiving the research feedback that we provide? And then the other thing I wanted to touch on, which I think you actually addressed to some degree, was this collaborative surveillance. And you made mention of event life cycles and geographies as one. These were two out of many points you raised. But with the geographies, I worry sometimes about the borders. We like to say that, say in Togo has eliminated a bunch of NTDs and so on and so forth. But, Togo is just next to Ghana, then next to Benin, next to Nigeria, and we are next to Cote d'Ivoire, and then Burkina up there. So one may think it's actually a bit of a misnomer when you say X has eliminated this and the guy next door has not eliminated it.
how best, and again, you touched on this a bit, can we address this issue of borders within the scope of what the real risk is, knowing that these pathogens and causative organisms, and actually even the socioeconomic and wider climate factors really do not know any borders?
Thanks, John. Two complex questions as expected. I think the first thing to say is, your question on how to engage with G-WAC and is something we will define together. So I'll give you just an example. In the development of the physical environment of the hub, so the last picture I shared, we have a space that will house 120 workspaces. We're filling only about half of that with WHO staff. The other half will be really to host colleagues working on specific topics that are important for us. And that is recognizing that the expertise required to deal with the complex realities of today cannot all be found or recruited for within our formal systems. So I very much look forward to defining specific areas, and I hope we can even start thinking about it now that our colleagues from the Robert Koch Institute are with you and others. The public health school is schools in Berlin. The key thing is to define areas of global health significance where you have a unique advantage, opportunity, both either in your capabilities or in your exposure to that threat, or in both, and work out how we can collaborate in thinking through the complex realities of that threat and how we can respond to it. So that's one immediate opportunity that I hope will evolve out of this meeting. To your second question, I absolutely agree with you that the political boundaries within which we have to think about concepts such as elimination are completely arbitrary and mean very little to the realities of life, especially in West Africa. Our colleagues working across countries, we have to really think about how do we collaborate better. And the hub is just one instrument to do that. There are lots of instruments in West Africa as well. The West Africa Health Organization, the new West Africa CDC, the individual countries, and really come together in a collaborative mindset and how to exchange that information. And it's not a week out of the hub, but we're definitely hoping to contribute to those discussions and the mechanisms, building the systems. One good one already that we have developed in WHO that many countries are using is something called EIOS, Epidemic Intelligence from Open Sources. And many countries are using this system already and making decisions. And within that system, you can create environments to share. So you can decide to create an environment where, as long as both countries agree to share information across a broader geographical area than is politically defined, but the leadership in those two areas have to agree that they share risk in common, and therefore are willing to share that information in order to mitigate the challenges that they face.
Any other question? Yes, please.
Maybe one more, then I do have to run. Sorry.
Yeah, thank you. My name is Stephen Kennedy. I'm from Liberia. Excellent presentation. Thanks very much. I really enjoyed the presentation. You spoke a little bit about collaborative surveillance. There's no question about it. There's no doubt, in fact, that collaborative surveillance has a significant impact in terms of better decision making, and it has the potential to avert potential outbreak. There's no question about that. But I guess what I think less emphasis was placed on is that for us in the honor resource setting of the world, say for example, Liberia, take a case example, Lassa fever. Surveillance is probably big. Eliminate the vector from the most affected community. It's a key challenge. Finance is a problem. So as a result, it has significant impact on decision making, and it creates a potential that we're going to have sporadic outbreak over a very long period of time. So the question then is, how do we address such a situation in honor resource or poor resource setting with the multitudes of problems that exist within the context of collaborative surveillance? Thank you.
Yeah, so my brother, I think you raised a very important question. But in terms of the resources available to countries, both from locally and globally, and I am fairly optimistic about the future in terms of resource availability. I think we have to work a lot harder to prioritize our areas of work within our government and advocate for that, but also advocate globally for more resource from the global opportunities. And globally, there's a lot of effort right now going on to mobilize more resources to focus on the work, because I think the pandemic definitely made the case for resources, and that is ongoing, like I mentioned, through the pandemic fund called the FIF and all the other global funding mechanisms. So I recognize the challenges, of course, across the continent, and also the variability of the depth of that challenge. And I don't underestimate it by any means. But this is not something that we can solve in a hurry. And I think groups like this are very well positioned to define the opportunities and where exactly we need to fund, especially in the intersection between research and public health, which G-WAC is very important in defining for the future. How do we support? There's a lot of discussions at the moment around vaccine manufacturing and things like that. Very important conversations holding. But at the same time, how do we support the training and development of the researchers and the scientists that will work in all these places, and make sure that the entire ecosystem is given appropriate support? And coming out of Liberia, like yourself, and I was in Liberia for many months during the response, I think there are many missed opportunities post the Ebola outbreak in building on the response in Liberia, and because the solutions were not as simple as many people imagined them to be. There was a lot of money going into building of infrastructure, of new labs and new public health EOCs, but that in itself is not sufficient to change infectious disease prevention, preparedness, and response architecture. We have to develop human capacity, develop supply chains, all these softer things that are a little bit more difficult to invest in, and work with local knowledge, local capacity to do so. So I think the key thing here is that I am completely committed to understanding the local realities and to collaborate in a way that recognizes the incredible amount of expertise that exists in every context, and therefore look to working with you through G-WAC, through the other regional structures, in developing a framework collaboration that serves the purposes of every individual country. It's a big challenge. None of this will be solved, but I'm hoping that by starting off with this spirit, that we can co-develop the future that we want to see in the world. So thank you very much, colleagues. John, I wish you a very successful rest of the meeting. And I look forward to continuously engaging with this. You've chosen a very important topic, one close to my heart, and I wish you all the best, and I look forward to the outcomes of your dialogue session today. Thank you.
Thank you very much. I think we should give him a round of applause for this. Yes.
Thank you.
Okay, so the closing remarks, 2 minutes for each speaker. Just 5 people, 2 minutes. So John, you start off.
Well, I had the privilege of, asking a question, and that took quite a bit of time. But just to say that I'm glad we've kicked this off. It is the first in hopefully a couple of series, and I think Vilm very eloquently explained what this is about. In as much as we are in a formal atmosphere, we really want this to be very informal and get to the depth of issues. Especially because us as academics and researchers tend to do a lot, but either do not engage, do not know how to engage, or we distrust the policymakers, policy implementers, or they distrust us. It's really important that there is dialogue, because dialogue is what ultimately, brokers a relationship and mutual trust and mutual respect. We've heard, stories of researchers, going away with data from public institutions and doing their own thing with it without recourse to the sources. We've also heard stories of public institutions refusing to provide what would otherwise be public information collected with taxpayers' money, making it available so researchers can use to develop or to do their research, which hopefully will improve policy. So really important thing we are doing, and I hope and when we're extending this beyond just Ghana to the sub-region, and hopefully to be useful.
Thank you, John. Vilm.
Yes, thank you very much. In fact, during my earlier statement, I forgot to say I'm very happy that all of you are here and that we are really here now together in the room. And this is, when we started putting together the proposal for G-WAC 2 years ago, we had this idea of having a West African policy dialogue, and now we are all here sitting in the room really to discuss pandemic prevention. I think this is really a great achievement, and I'm happy that we have come so far, and I look forward to now interacting with all of you. Thank you for coming to Ghana. I know travel arrangements weren't always clear-cut and easy, and there has been a lot of planning, so I'm very happy that we have all made it and will be able to address the topics now in the next 2 days.
Thank you, Vilm. Johanna?
Yeah, I'm going to say a couple of words just that were mentioned. So first of all, I wanted to say on behalf of the RKI, we're very honored to co-host this policy dialogue, and we'll explain a little bit about the background to that in the first session. So I won't pick up the theme that Chico posited in the hub of our partnership and how we can use that to connect with G-WAC. So we'll have a bit of time to focus on that. I think from our perspective, I just wanted to say, as a National Public Health Institute, we are obviously very much in this space between research and policymaking. So today's event is particularly important to us, and that's also why we're keen, not just because we're part of G-WAC, but also why we're particularly keen to support this. So the center that I had does at the RKI essentially does the national pandemic preparedness, but with international partners. But the reason why the focus for today's policy dialogue is so important, I think, is the pandemic showed 2 things, or 2.5 to somebody working in that space I work in. The first is, I think, the massive importance of national level, right? So I think it's really great that we can come together and really share at our experiences at national level, because that's where the hard work has to be done, right? That's where those outbreaks are contained that Chico showed and so on. And the second thing is, for me, what it showed is that no national level can do it alone, right? So national level needs to collaborate with other national levels. So that's why I think a regional aspect, both in G-WAC, but also in this policy dialogue, is so crucial as an approach. And those ties and strengthening those ties are so important. And even as a National Public Health Institute in Germany, it's so important to be working with all of you. And the half point I wanted to mention is that my experience over the past 2.5 years has really been that policymakers have understood the absolute importance of data and of surveillance systems in a way that they have never before, right? So in my department, there's a unit called an epidemic intelligence. Nobody knew what that term meant. And now everybody in my government knows what it means. We have this hub in Berlin and people are asking for information around it, right? So I think now is the time in a way to as researchers, but also as those working in between and going in between, to better articulate that value chain, if you want, of how we get from the better data to the better analytics to the better decisions, right? So we have to sort of find a way to broker that. And that's why we're particularly keen to sort of, or happy to support this policy dialogue and also look really forward to the coming days. So thank you very much all for traveling, for coming here, and really look forward to the open interaction. Thank you, Chair.
Thank you, Joanna. Proper indirect.
So I want to really appreciate the organizers, John and his team, for inviting me here. I'm very honored to be in this meeting. I realize that I'm a minority from University of Ghana. This is a very heavy KNUST event, even though it's in Accra. It seems I'm the only one from University of Ghana here. So I feel honored that I've been invited to this table. On the theme about pandemic preparedness, usually my opinion about this is that I believe that the best way to prepare for a pandemic is to have strong ongoing surveillance, because what the current pandemic has taught us is that the countries that were able to respond best were those that had strong systems in place already for dealing with endemic diseases. And so when there's a pandemic, it's much easier to redirect resources and expertise to respond to a pandemic if you have a strong ongoing surveillance system. And I think that's one of the lessons that we should learn from this, that we should not overemphasize preparedness for a pandemic. Let's emphasize preparedness for our daily challenges. And when there's an emergency, it's much easier to respond to an emergency that way. I mean, later on we have time, we'll talk about WACB, for example. Our role we played throughout the pandemic. We were able to do that because we're already building capacity to do these type of things for other diseases. Most of our capacity was for doing malaria, but we're able to turn that around and use it to do COVID-19 work. And that's what put us in a strong position. The last thing I want to mention is that there's already a lot of emphasis on the need for strengthening at the country level. And I think that's really critical. And particularly with data, I think there needs to be much more data integration. I have suggested to our Ghana Health Service that they need to set up a data team that has the technical expertise to basically collect all the genomic data, cure it and turn it into usable information for the the Ghana Health Service on a daily basis. So we have cases we are doing genomic sequencing, WACB we're doing genomic sequencing, Noguchi they are doing it, UHAS doing it. Even within country, all our data is in silos. There's nowhere that you can find all the genomic sequences in Ghana in one database, except in GSAID, which is in the cloud somewhere. So it is critical that the Ghana Health Service can wake up in the morning and say what variants are in Ghana as at now and click a button and see. They don't have that. They have to call us and ask us, and call cases here and ask them, and call UHAS and ask them what they're getting. This should be something that should be ongoing. And that is because we need the technical expertise at the national level. We need strong bioinformatics capacity. We need strong data capacity, data analytics capacity. And this should not only be at the academic level, but also at on the level of the public health institutions. And if we can build that capacity, then we will be ready to respond to any emergency because there will be an integrated system that can provide information within a short period of time. Thank you.
And then the last one, Professor Akim Harrow.
Yeah, thank you very much. Actually, I was surprised to be given a few minutes, and during the great talk by Dr. Chikwe, I decided to bring in the perspective of the entities, since there are a lot of entity researchers in our G-WAC consortium, and some of you may have already asked why is that so. So, for example, there's Professor Alex Debra, with whom I have collaborated for 20 years on NTDs, and Dr. Linda Batza-Debra, and also Dr. John Amwasi is head of the African Network for NTDs. And so what does NTD actually, NTD research and also NTD implementation bring here on the table? And when Dr. Chikwe said in the beginning, if everyone does the job in a pandemic, it doesn't make headlines. And it's a little similar with NTDs, I would say, because there's a lot of engagement to control NTDs as much as it is with the global big three like malaria, TB, and HIV. And the preceding speaker has already mentioned, we can build upon these capacity buildings and also on the digitalization of data that is also happening in to a large extent with NTDs, build this capacity and be better prepared. You can only be prepared against pandemics so much, but what you can do is prepare the people, get data systems, digital systems in place that you can respond more quickly. And I think this is what we want to bring together also within G-WAC, and where we see our place with entities. And I think that's also important that this is a constant capacity building effort that we have been doing over the last years. A lot of PhD graduated that are now lecturers and professors, mostly at KNUST, but also elsewhere in Ghana and in other partner countries of our networks that we have on entities. So we are really happy to bring this together with the more preparedness and public health aspects that Johanna mentioned, for example, and that we think this is of very mutual benefit. Thank you.
Thank you, Akim. We left out the National Centers for the Coordination of Response Mechanism, Dr. Siedu. Is he here? If you could just give us some remarks, then we end.
Thank you very much. So like I said during the introduction, the center is a new creation between ECOWAS and then member states. And as I mentioned, 12 countries at the moment have set up their centers. And there are 3 more that are yet to set up: Togo, Senegal, and Cape Verde. But Ghana is one of the few countries that was established with an act of parliament in place in August last year, and the center was launched in November last year. So virtually we are on the 12th of November, we were 1 year old, and the focus and as the presentation was being done, it was really resonating as far as health intelligence is concerned. But beyond health, we are looking at the other human security threats, and you recall that during the COVID-19 pandemic, security, border control, customs, immigration became very critical beyond just what health would have done. So that kind of coordination hub has been strengthened, and that's the focus of the center. The center does not respond, but works closely with all the responding agencies, ministries, and departments, and also to hazard some response options. And then ultimately we do some kind of evaluation. So I'm also very excited to be here, and I think it gives the center also an opportunity for us to do some kind of collaboration and to commend the earlier keynote presenter that yes, if we do not collaborate, then we might not be able to achieve what we need to do. But again, in our center, our role is to collect data. It's I would say it's a center of excellence for data collection and research and analysis. And so we are also open to collaborate with other agents and institutions to be able to work together to secure the human person. So basically that's it. Thank you very much.
Very much. Before we go for the coffee break, I would like to first thank His Excellency, the German Ambassador, Daniel Krul, for his support for G-WAC and this activity. He has stood behind us steadfastly, and we appreciate you, sir. Now, there is one thing I will not do, attempt to give closing remarks summarizing what the speakers have said. So we're going for the group photograph, and then we go for a coffee break. Thank you very much.
So we'll step out for the group photograph. So out the doors, and the photographer is there. He'll direct us how to stand.
And then we will take reactions also from and perspectives from the different African countries and also from the plenary as we have gathered here. And so I will hand over to Professor Kim Horov to introduce the session and then also the speaker for the first presentation. Thank you.
Yeah, thank you, Daniel, for the introduction. And dear all, as you can read in the program, after the WHO hub office in Berlin has been founded, there rather quickly developed a collaboration to the National Institute, Robert Koch Institute in Berlin, to bring this to life. And one aspect was consultations on the national level with several countries, what from their perspective is the most important that should be done and should be implemented by the hub. And instrumental for this was the director of the Center for International Health Protection. The G in German stands for Gesundheitsschutz or Health Protection. This is why it's called SIG. And the director is Professor Johanna Hanefeld. She set this up together with her colleague Anne Meyerkort. So if I may ask you, Johanna, to share with us your first slides, please. Need a microphone?
Can you hear me? Wonderful. Okay. So yeah, thank you. So I'm going to introduce, I'm a little bit going to contextualize what this first session is about. And it's intimately connected to what we just heard, what Chikwe introduced. So I mentioned that the RKI, the Robert Koch Institute, is Germany's National Public Health Institute. And I won't go into it too much, but just to give you a sense of it, it's made up of 8 departments, and my center is one of these 8. So I'm effectively the international department of the National Public Health Institute. And overall, like many of your institutes will be, our mandate is to protect and improve the health of the population. And we have many tasks, but summarizing 3 really is around data collection and surveillance and the analysis of that. So all the routine surveillance of population health in Germany lies with us around infectious diseases, biological hazards, but also non-communicable diseases. We then also develop policy and medical expert guidelines and recommendations for preventive strategies. So we provide the recommendation on treatment of certain pathogens and guidance on how to deal with this to public health offices. Important to mention is Germany is a federal country, so we don't have, we provide guidance essentially, and then the district offices implement that. And this is the function of my center, we support partner countries with improving preparedness for disease outbreaks and health crises. Our work overall is on 2 pillars, is based on 2 pillars. It's around evidence-based research for decision-making. So it's very close to the title of the session. And we also give independent advice for specialists. So both policymakers, but also importantly, we provide guidelines that then guide some of the reimbursement mechanisms in our health system, so that effectively become national guidance on, for example, vaccination and so on. So very similar to public health functions, I imagine, in your country. So that's our institute. And following the outbreak we've already heard reference to of Ebola in West Africa, the legal mandate of this institute was expanded to include the international work. And here, this is just the press release launching it. So to say, the work that my center undertakes is relatively new. And here is the structure. So it's a department of about 120 scientists now. The RKI as a whole has about 1,400 people working there. And we effectively work through 4 units. So we're the Center for International Health Protection. In Germany, you abbreviate this CIC. So this is, Achim Hörhoff said this very nicely. So it's a bit confusing, actually, because we always say like, oh, CIC, and then all our international partners are like, huh? But anyway, so that's us. And we have basically an epidemic intelligence. We've got a unit that does evidence-based review. We've got a unit on preparedness and response, and one on laboratory support. And then we host the program office for the German biosecurity program. We host something called the German Global Health Protection Program. And that is what I wanted to show you here is we also now have an office that collaborates with the WHO hub on epidemic preparedness, epidemic and pandemic intelligence, sorry. So GWAC hub, the Berlin hub he introduced, collaborates as one of the founding partners with the RKI, and this collaboration is hosted within the department. Just to give you a sense of our activities, you can see this is a map of the COVID-19 exchange and support activities we undertook over the last 2.5 years. So you can see we have a strong focus on Africa, some activities also in Central Asia and the West Balkans, which are strategically important for Germany. So this is just to give you a sense of where this sits. And then, and this is the introduction to what we will do today, is in September 21, the hub that Chikwe referred to was opened in Berlin, and it was created through a donation by the German government, by the Chancellor at the time, Angela Merkel, to the WHO to increase the focus on pandemic prevention. And the hub has because it's based in Berlin, but it's a hub for the world, it has 2 foundational partners. One is the Charité Medical School, and the other one is the RKI, the Robert Koch Institute. And here you can see, so on the day the hub was launched, this is Dr. Tedros, together with Professor Wieler, who's the president of the Robert Koch Institute. We signed a memorandum of understanding that governs this collaboration. So we have joint projects, and Chikwe referred to some of those. And I think it would be great if we could, during the day and a half we have together, also explore how we can be a bridge for you coming to Berlin and working with the hub. And develop some concrete ideas. But for 2022, and that really brings me to what this session is about, the hub asked us to do an independent consultation on how WHO, how this intelligence unit that Chikwe presented can work better with national public health institutes or national public health actors. So including the university sector and so on. So how can the WHO hub work at national level around these topics? And I think Chikwe introduced this very eloquently. It's not about data extraction, it's about how do you strengthen and build those capacities and systems together. So we undertook this consultation, I have to say, for conflict of interest. We're funded by the Gates Foundation, supported through a grant by the Gates Foundation. And we did this through literature reviews and through in-depth in-country work. And what we hope to do now to start us off is my colleague, Dr. Anne Meyerkott. She's a research scientist who works in this office but collaborates with the hub in my department. She will be presenting some of the initial findings from this consultation that we've had. And really what we had hoped to do today in this session is to get your input and your views, whether this accurately reflects the reality and the challenges that you face, and how we can work better together. We will take your feedback back to Chico and the Hub. We will be producing a report with a set of recommendations to them, and we'll include an overview of our discussions today there. So that was the introduction from my side. And I think I just hand straight over to Anne Meyerkort with the presentation. This is the second presentation from the RKI, who will be presenting both the findings from a literature review that we conducted, as well as the country consultations.
Just to say, we are chairing from the sidelines because otherwise we can't look at the slides ourselves. So please.
Perfect. Thanks so much, Johanna Hanefeld, and thanks to the shares. So I'm very excited now to present you some of these results and recommendations. As already mentioned, this project entails sort of like two components, and I'm going to start with the first one, which is the literature review. Oh, sorry, can I change the slides myself? Oh, with the green button, this one. Ah, perfect. Okay, great. So the literature review basically focused on approach, challenges, and opportunities to develop human capacity in epidemic and pandemic intelligence. So the rationale for that was that the human capacity development was once set as one of the strategic objectives of the WHO Pandemic Hub, and we decided to focus our literature review on this. And the aim was really to try to understand challenges and opportunities on how to expand the human capacity in this space. So the method for that was, first of all, it was an analysis of peer-reviewed articles. And the second component of it was a review of policy documents in that space by a Google search. Here you can see our inclusion criteria. So we decided to include only studies published from January 2014 due to the Ebola epidemic in West Africa. A lot of, I think, generally surveillance practices changed. So that was our reasoning for that. And to only focus on English language articles. Some of the limitations include that it was only restricted to the English language, and a quality assessment due to the involvement of policy documents was not possible. So now, first of all, presenting the results of these peer-reviewed articles. So we screened, so 68 full texts were screened, and we included 30 articles. And it was a thematic approach that we used for that. And basically these 5 themes occurred. So just starting at the top here, the first one being the role of communities in the disease surveillance workforce. So I guess generally, so community surveillance, I guess we all know about it. So it was seen basically as an opportunity to expand in that space. And for example, opportunities discussed were, for example, the involvement of community monitors. So specifically training the community there in identifying and reporting a broad range of event signals, and things like, voluntarily reporting through mobile apps and so on. The second was professionals contributing to the workforce. So what was basically seen as an opportunity was to expand the importance of this interdisciplinary and variety of integrating non-traditional disciplines in that space, such as data scientists, decision scientists, implementation scientists, really involving them in the surveillance workforce. Third, what was discussed by the literature was the one approach. So there was seen a opportunity for joint training programs in that space. Fourth one, the digital tools in human capacity building. So there was basically a discussion going on around the balance of investing into new technical tools or data tools versus investing into human resources. And opportunities where that was seen, for example, was then through, for example, crowdsourcing platforms. So this is now sort of like also focusing on a bit on the role of communities. So where individuals can basically upload their own data, such as, for example, it was used in this Outbreaks Near Me platform, and AI and general discussion of AI and automation processes. And the final theme that appeared was training of the workforce. So interestingly, of these review of the peer-reviewed articles, more than half of the included studies actually circulated around the field epidemiology training program. And challenges discussed there were, for example, the academic accreditation of the field epidemiologists, a lack of data analysis practices, ensuring sustainable funding and onwards, basically contractual developments of field epidemiologists, the so-called brain drain, so really the retention of the workforce. Then in regards to results from the policy review, so 20 documents, reports, policy briefs, and concept notes were included. And a lot of these themes were actually overlapping with what we found in the peer-reviewed articles. But interestingly, so in the peer review, there was much more, so because more than half of the included studies focused on the field epidemiology training program, while in policy documents, there was much greater focus on these non-traditional disciplines involved in a surveillance workforce. So social sciences, for example, was interestingly not discussed at all in the peer-reviewed articles. So I think this really just like reflects and shows a need for more research exploring these non-traditional disciplines outside of epidemiology. The role of communities was reflected in both reviews, but it was also in the policy documents sometimes discussed controversially, while some saw opportunity, others called for more professionalized and predictable workforce in the space. And the One Health approach was definitely also seen sort of like by both reviews as seen equally as an opportunity, while it was more discussed in policy review. So now, what sort of like recommendations did we come up with that were resulting from these results? So the first recommendation is basically encouraging member states to aim for diverse and interdisciplinary public health workforce. So basically advocate for the role of non-traditional disciplines involved in the surveillance workforce. Thinking of something like establishing a register, for example, for social scientists at the national level who would be readily available to provide expertise to district communities if needed in outbreaks, responses, and generally in enabling more research of the role of non-traditional disciplines. The second recommendation, finding a balance between the human workforce and an automated workforce. So what I was saying earlier, this balance, investing in new data technologies and the human workforce, and discussing the balance in that, and also setting ethical, also changing ethical standards in the use of sort of where would there be an opportunity sort of like for artificial intelligence to support, sorry. Then the third point, or the third recommendation, was all about sort of this quality assurance. So creating a global quality framework for the public health surveillance workforce, for establishing standards on the public health surveillance workforce for outbreak times, but also non-outbreak times. So by that, we really meant setting core competencies of a global public health workforce, and also elaborating sort of more on these characteristics that are needed for surveillance, for adequate surveillance in outbreak, but also non-outbreak times. So we were discussing something like having, you know, these key points like something like 1 to 200,000 field epidemiologists, for example, as a set standard. So discussing these sort of targets that one could think out. And so the final slide on recommendations, the fifth one that we were discussing is promoting the integration of communities and individuals into the disease surveillance workforce. So also in regards to that, basically defining or setting standards on requirements for volunteers and the community involved in disease surveillance workforce, and evaluating really also these tools directed to the public to engage in these disease surveillance workers. So which ones are the ones best supporting the efforts of communities. Sixth ones, discussing the independence also from donor funding in regards to the national level, setting priorities in their workforce targets and training of the workforce. And the final recommendation is also addressing these challenges specifically in the field epidemiology training program. So supporting member states' independence from donors, funding, again, with this training agenda in terms of that, and providing also job classification for graduates, and tackling the issues with the retention of the workforce, ensuring follow-up contracts. So these were, let me just, so this was basically all our findings and recommendations from the literature review. I'm now going to talk more about the in-depth qualitative interviews that we've undertook. So basically, the second part of the project was that we have done focus group discussions and in-depth interviews. We've selected people from five countries, and the aim of that was also to provide basically this strategic input and on the country engagement and how to support across the functions of the WHO Pandemic Hub. So here you can see these 6 functions, and they were once set out as basically priority areas from the WHO Pandemic Hub. I'm not sure if they sort of like, they were set out sort of like at the beginning as these priority areas. So, and our interviews basically all focused around these 6 functions. So human capacity development, tools and technology, development, data sharing, normative functions, support for collaborative environments, and policy setting and advocacy. So as I said, the methods include in-depth interviews, focus group discussions that we undertook in these 5 countries. So from West Africa region, Cote d'Ivoire, but then also Ecuador, Namibia, Madagascar, and Saudi Arabia. This was the selection criteria based basically on geographical variety, but also feasibility because of already existing partnerships with some of these countries, and basically seen as a basic requirement for them to have an existing basic surveillance structure. We then try to triangulate the findings for literature review together with these in-depth interviews and focus group discussions. And also a big part of these methods is also the discussion of results and recommendations. So for example, 2 months ago, we had a meeting with IANFI, so the National Association of National Public Health Institutes meetings, who did a project alongside ours also on basically finding, surveillance or exploring surveillance also structures on their side, and having the possibility to undertake also a survey. So I'm not sure, some of you might have been actually involved in this. And then also we really want to use the opportunity of the West African Policy Dialogue today, so really to discuss this with you and encourage you to engage the discussions and really be involved in a fruitful discussion. So what are some of the, I'm now going to run through a few themes that appeared from these in-depth interviews and focus group discussions. The first one being data sharing. So basically what we saw is that there are existing communication channels that are well established, but often informal and insufficient. So this is what our interview participants reported. So on a national level, it was seen as a challenge, the private sector information exchange. So what was reported by interview participants was, for example, that often the private sector had no obligations, no way to share data with the public sector or on the national level. And so there was seen like a lack of data sharing in that space. Furthermore, on the human-animal sector information exchange, so challenges were seen there that, first of all, there's a lack of awareness of the human side. So professionals involved in that side, but also then on the animal side, so also vice versa, why there was a challenge seen. Then these two sectors having in general different priorities. Diseases that might be of a priority to one sector might not be the one for the other one. And so data is less shared than of not priority diseases. And also missing frameworks in this space that would allow for a structured reporting to each other. Then I guess a big one here, so public health data are political. So a challenge was seen that basically the reporting, it was unclear the reporting structures and causing then much confusion. Have the authority when to report. Next point, data shared up the system but not down. I think that entails 2 points. So first of all, that often, so data, or what was reported by the participants was that data was shared up the system, but then they could not access for their own districts this data. And also there was no possibility for them to access data for neighboring districts. And for that sort of limiting their ability to make decisions specific for the district. And then also the fragmentation of data tools. And so I think also in terms of data sharing, so data sharing tools, there were different options. And I think all of that together causing basically the silos of information fragment surveillance system and the limited ability to monitor and respond to outbreaks. So the recommendations that we drawn from that is there's a need to define normative frameworks for standardized data sharing and also really define data variables and timelines involving the private laboratories and clinics to share surveillance, to share data within these surveillance structures, and also for the One Health sector shared in-betweens. Next orientation, and that was actually often reported by our interview participants, to simplify basically also these data flows and providing tools that make it easier and facilitate the sharing and analysis of data. And I think if I can just read out one of the quotes here on the bottom right. So make a system that is better and easier. We want to share, but it's complicated to share it. I think just really underlines that the challenge of these data sharing and that the tools or data flows that they are lacking. So it really needs to simplify it. The next theme that appeared in the interviews was that of analytical practices. So generally what was reported by the interview participants was that these analytical practices and analysis analyzers are limited, mainly through the manual processes. So challenges that were reported were, for example, large burden on surveillance systems due to manual data processes, and generally a low analytical capacity to detect signals. And I think due to a few factors, first one being a lack of general public health surveillance workforce, a lack of personnel, lack of training, but also big one, lack of sort of like integration of multiple disciplines involved in analytical processes. And that all contributing to delayed outbreak response and also issues with overstretching the human resources. So recommendation, I think, is a much more sort of like holistic one that you take from that. So generally, there's a what we've seen is that there's a need to create a long-term quality assessed training agenda, and a good starting point with that could be strengthening of analytical capacity. So I'm going to come back in a second also in general to sort of like training and capacity, but I think this analytical capacity space could be definitely a starting point, but I guess it's not going to, the solution is not to just provide more trainings, but needs to be seen in a much more holistic and wider approach to quality assessed trainings. Next point regarding so diagnostics that came up during the interviews. So what was seen or what has been reported by our interview participants was the lack of reagents, slow turnaround times, and delayed signal detection resulting from these lack or contributing to delayed signal detection. So if I can also just read out that quote, because I often think it makes it just a little bit more livelier, his presentation of challenges and recommendations. So someone said about techniques, well, I don't know what to say. It's like that. The same thing with PCR, the same thing for sequencing, the same thing for NGS sequencing. Every time it's about advanced techniques, we have problems to get the reagents. You don't have a factory in Africa. So I think just really showing the well, the lack of sustained reagents, suppliers, funds to purchase reagents. One country also reported that there were high importing taxes for reagents and complex bureaucratic processes to purchase these reagents, and generally also in regards to logistics, this lack of sample transport capacity because of a lack of arrangement with couriers or vehicles in order to be able to transport these samples right from the district to a laboratory, to a lab that could undertake the analysis, diagnostics. So in general, non-sufficient materials for disease diagnostics were reported contributing to this delayed signal detection, and the logistical aspect of long transportation times delaying signal detection and responses. So some of the recommendations we discussed then regarding diagnostic would be to strengthen these structures for purchasing reagents, for supporting, for example, regional bulk purchases or production sites, and supporting really these logistical processes. Another one could be, for example, if it is at the interest of governments to support reagents, there could be an idea of, for example, waiving high import taxes and through that making reagents more available, and advocating for really these contractual arrangements with sample shipment companies so that samples not only, so for example, in one country it was reported that they had, for example, a contract with shipment companies from one country, so for one disease, but not for others. So advocating really for these contractual arrangements. Then the next theme came up, sorry. Yeah. Yeah. It's quite a lot. Yeah, apologies. Okay, so just in regards to sequencing. Basically there's been an absolutely rapid increase in sequencing capacities, well, thanks to COVID-19 pandemic. But however, there's still large inequities of obviously capacity to monitor these spreads of new pathogens and sublineages. So, for example, what has often been reported by interviewed participants is there's a lack also of normative frameworks for sequencing data sharing. And so even if they do have this data, they are unsure of where to upload it to, and generally for the sharing of it. So, so WHO has just published some guiding principles, basically on this, that setting out some ideas for principles on such new data platforms, and principles on where this data or how this data can be best make use of, also in terms of sharing it. Yeah. So there was something about tools and technologies. So now just regarding training and capacity development, because that was also the focus of our literature review. So basically, what was seen as, or what was reported by the interview participants as a challenge, is that there's budget restrictions, lack of trained personnel at the country level, limited health force and lack of capacity to analyze the data. And challenge was that there's multiple, or what is reported was multiple training programs to address these issues, but this training is often very much fragmented in the nature of it. And often what was reported was there's no definitions of core competencies of an epidemic intelligence workforce, and therefore these trainings are often provided for the same cohort of people, trained skills, and then but not overapplied due to these overstretched personnel who received over the same trainings. So basically, in summary, so there's a lack of this training agenda, and so but that may lead to training being dictated by funders' priorities rather than the country needs, and an underuse of laboratory and epidemiology data was also seen as a challenge, and really this integration of both of these, the lab data as well as the epidemiological data to combine this. So recommendations. So recommendations that we discussed then was really, as I mentioned before, this development of a nationally specific, so the quality ensured training agenda, really setting the priority areas of the nations at the forefront, developing it sort of a long-term and in a holistic approach involving non-traditional disciplines, and also with the focus on integrating and strengthening the laboratory as well as epidemiology data on that level. And also, what was also seen, or what we discussed as possible recommendation was to advocate for funds to also conduct more simulation exercises, because that was also seen as an opportunity by the nations that they would have liked more experience with this. So that was training and capacity. Sorry, in terms of time, I might just skip the last point, which was about basically One Health. And that often was reported, and where challenges were seen, and basically a need to integrate more the animal and human side. And that just leaves me to say a massive thank you to, first of all, my colleagues at the SIG AKI WHO Hub team in Berlin, who conducted this research with me. So Dr. Lenka Körner, Dr. Joaquin Baruf, and Dr. Caroline Gottsche, who was leading the literature review. And most importantly, obviously, our partners and interview participants internationally. Without them, this would have not been possible to undertake. So thanks so much.
Yeah, thank you very much to the two speakers for this very comprehensive analysis. There's a really big food for thought, I would think. There are so many suggestions and identification of shortcomings that probably everyone has to digest. But still, I would like to hand over to our audience. What you think is still missing from the national perspective? Or Walter Bruchhausen has a question, a comment.
Yes, many thanks. That was really very broadening our perspectives here. We have done with our research partners in India for the last 5 years several studies, primary research on intersectoral collaboration in One Health. And one of the main points we found at all levels, that was from municipal up to down at community level, is the issue of incentives. I mean, you mentioned some of the problems, overburdened staff, the brain drain and so on, but to turn it positively, what could be incentives really to increase collaboration? And what we found actually was at the, for example, municipal level, if it's recognized by the superior levels. Yeah, so collaboration is always an additional burden. You need to devote time to things, although you're already overburdened in your own sector. Yeah. So where do you get these incentives to do this collaboration? And one is really if it's ordered by superior levels and recognized in the end by career opportunities and so on, that intersectoral collaboration is a value and it's not just an additional burden. Second level with the private sector is really now in the pandemic, how to get them involved in the whole enterprise, to really also take them into the supply chain for oxygen, essential medicines and so on, was really essential in getting them to collaborate. And then in the end, interestingly enough, we really asked who would be ready to do this kind of data collecting as an additional task. And that was really the community health workers at the lowest level, because in India, like in other countries like Ethiopia, they are paid for each delivered item. Yeah? So they take part in 20 or 25 different healthcare packages. And if you add this additional package that they are paid for every case of a zoonotic disease they detect, they are ready to do this work. And they are really the ones that visit the households, the families, and see the sick animals and the sick human beings. So that could be really an entry point for this kind of data collection that is perhaps sometimes missed in the policies and in the research, rather focusing the national level we have so far. Yeah, thanks.
Perhaps we can ask, so maybe I can ask the colleagues from the different countries. So around what you mentioned is what we found, and this is for One Health more than other, is these complete silos of surveillance, right? So HIV surveillance you can anyway not touch because it's a funder, right? So then there is a disease surveillance around respiratory infection. Then there is a disease surveillance around One Health. The One Health, even with the triggers, even if you have the trigger of an event, even if you had an event-based surveillance, it takes a long time to make it to human. I mean, the connection is there, it takes a very long time. So one of the things that our recommendation to the hub is look, you need to do something. As WHO, you need to say something about this. You cannot, even WHO has got, we know, have their own silos in the surveillance system, so they haven't integrated, right? So this is something that we feel very strongly. I would be really curious to say, so Cote d'Ivoire was included, the colleague, but we had the opportunity to visit, but I would be really curious to hear a bit, if I can push you a bit, Ghana, Liberia, and so on, to just hear what your experiences are in country, and practically how you deal with integrating that. And One Health, to be honest, was the worst. Like everybody says, okay, One Health we want to do, we'll do a national action plan, but in terms of integrating the, sorry, I speak very open, no? But like in terms of integrating the surveillance, very long way to go. So I'd be really curious to, if I can push a bit more.
Okay, my name is Romain Glele-Kakai. I'm from Benin. I would like to talk about an initiative we have in Benin since 2014. So we set up a master and PhD program in biostatistics to strengthen data analysis capacity in sub-Saharan Africa. And this program, these two programs are in English, and we attract students from different countries in Africa, sub-Saharan Africa, and the program is supported by the German Academic Exchange, that, and also the World Bank. Last year, we received support from EDCTP to train epidemiologists and biostatisticians. So we have now about 20 countries represented in this program. So I'm talking about students coming from different countries in Africa. So we are really trying to build capacity in this field in sub-Saharan Africa. So that's what I would like to say. Thank you.
Yeah, thank you very much. You want to? Oh, okay, yeah. Go ahead. Yeah, please.
Yeah, good afternoon. My name is Steve Kennedy again. I'm from Liberia. I think your description is quite adequate. There's a lot of information. How to digest them is quite challenging. The question is, how can you fragmentalize all those information into what can be addressed from a policy perspective, what most likely may be difficult to address? And let me give some example from Liberia perspective. Say, for example, the Ministry of Health funding by donor agency. In Liberia, a huge proportion of the funding that goes to the Ministry of Health is based on donor funding. The country has a lot of priorities, limited national fiscal budget. So to be able to share the budget all around, health cannot get its share to meet the Abuja Accord. So donor funding comes into control that. You mentioned that as one of the key challenges. How can we address that? That would be quite difficult because I don't know, to be able to take a huge proportion of the money, it may affect security, it may affect education. So I don't know. So the question is, how can we fragmentalize all these issues? That's one example. The second example is, we have one national reference lab. It's in Monserrado County. You're in a country where the entire road network of the country, I don't know, maybe 20%, I don't know. Also, far away, maybe about 200, 300 miles from the capital where you have the national reference lab. You have the forest basin, and these are the areas where we have these emerging infectious diseases, outbreak of Lassa fever, outbreak of Ebola, or trans-border transmission of Ebola. To collect sample from there, we don't have regional laboratory. We cannot do regional testing. So the sample has to be collected from there, transported by road transported from there to Montserrat, 200, 300 miles. That is another challenge. We don't have helicopter to use, motorbike to transport them. It's maybe 3, 4, 5 days. The cold chain problematic for these samples. So again, that's a huge, that's a very huge issue to address. How you address that in my country, I don't know. Is the government able to create road across the country and pave them? Again, I don't know. Political, the politics involved in data. In the public sector, you have to be mindful as to how you mentioned that. I'm just giving some of the examples you mentioned. You mentioned a lot of excellent things. Which one do we have control over? Which one we don't have control over to be able to influence better decision making and better data? You know, that's what I keep. I'm conflicted. You know how to address that. If your position in government, you are appointed by the central government, so the aim is to promote the agenda of the central government. Anything that is contrary to the agenda of the central government in terms of data at the Ministry of Health, if you release that into the public sector and they get to know that those information are released by you, you lost your job. You know, so how these things are addressed, I don't know. But maybe the best way to address, the best way is that if you were to take all those information you presented and let's segmentalize them, which one we may have control over to better influence decision-making, to better influence the use of data. I think that would be helpful. Which one we may have limited control over. You know, so I think that's the way to do that. But there's a lot of good information you presented. I enjoyed them. Some of them we already know, but some of them we have limited control over, you know. And the part of the world we live, not Germany, not America, not Europe, the part of the world we live, we also have to be very mindful as to how we carry ourselves in the public health sector. It has influence not only on our position, but our long-term professional growth within the sector. You know, so these are some of the challenges that I want to advance from a very practical experience. Let us understand that as we discuss these issues, you know, let's be more practical too. So that's just all I wanted to say. I have more, but I'll stop here to give other people the chance. Thank you.
Okay, so I think there was a lot to say. I think maybe, but one thing but a couple of things to respond is so I think that it's not, I mean, this hub has evolved and it's about what role can this hub play. So my feeling is one of the functions they defined and they asked us about is around policy and advocacy. And I think I know exactly, even in Germany, if you are at national level, there are things you cannot say, right? So about data sharing. And I think, but if the WHO hub can do some of this advocacy and can be an advocate for that. So I think that is an important point I would take from what you say. The second point to say is and Chico mentioned this in his presentation, is there's this new fund by the World Bank, right? The fifth, which will become operational next year. And it's looking to support aspects around, in its first cycle, funding around collaborative surveillance and the public health emergency workforce. So also coming out of the same processes. And I think right now they are looking for countries to articulate where should we put that precisely in the areas that we are talking about here. So that's why I think there are opportunities. And I think it's for us to articulate the challenges in a way that they think how can they address this through funding. So what you mentioned for your country, Liberia, I think we heard in many of the countries around the siloed surveillance systems, for example, because they are funded by different donors or because they have monitoring structures have emerged in response to monitoring a donor intervention, so the treatment programs and so on. And the question is how do we how do we integrate that, or what are some practical steps? So I'm going to try again to turn it back to you and ask if maybe some of the other countries, or maybe in Liberia, if you have attempted to do something like this. So I heard, for example, a positive perspective on this has been which we heard also in our data collection, is all countries are so much more sensitized to the need to collect data. Because we've had all these vertical programs that have come with so many indicators, at least there's now a trained body of data entry personnel. So I question, just to push it back to you, is really what would be the priorities be in your countries, or do you think there are ways in which to address that around the data sharing, for example?
So thank you. So I will speak my mind on behalf of Ghana. I think generally we agree on challenges, but if you look, let's say in the last decade, there's a lot of improvement in whatever we are doing. I recall in 2008, we started something we call Project 5's Lives. The idea was to improve under 5 mortality or assist Ghana achieving the Millennium Development Goals. But over the period, whilst we were working on it, it became evident that many projects